Okay, I think we'll go ahead and get started. My name is Connolly. I'm a pediatrician here at Henry Ford and also a proud member of the Global Health Initiative, as well as the Health Disparities Research Collaborative. A few housekeeping announcements before we get started with our last panel of the day. First of all, if you have not yet voted for your top 3 posters, you can do so by using your cell phone. It's located in the back of your program, so if you could do that within the next few minutes, that would be great. The next announcement is that after this panel and our next speaker, we are going to be having a reception after. We encourage all of you to stay. There will also be both beer and wine to make the conversation a little bit more lively, perhaps. So you're all welcome to stay, continue the really important conversations we've been having throughout the day. So our third panel this afternoon, and again, congratulations to those of you who have come back after lunch. I know there's always a trickle away, and so you all are the diehards who are here this afternoon, and I'm really happy to see you that you've come back. Our third panel is regarding building clinical capacity through partnerships, and we have 2 incredible experts to talk with us today. The first is Dr. Zulaika Ali from Trinidad and Tobago. She is a pediatrician like myself and a neonatologist. She is professor of child health neonatology at the University of the West Indies. She was co-coordinator of the University of West Indies HIV/AIDS response program to strengthen the university's ability to respond to the epidemic. She founded the UWI telehealth program to assist children with medical problems that could not be diagnosed or treated locally, by accessing specialists from sick kids in Toronto via real-time video conferencing, and was awarded the most innovative medical advance in telemedicine by the Trinidad and Tobago Medical Association in 2010. She also established the Trinidad and Tobago Health Training Center to train healthcare workers and has led collaborations among other Caribbean countries in that effort as well. The University of the West Indies awarded her the Vice Chancellor's Award for Excellence in Research and Public Service in 2012. And today at Henry Ford, given recent events in which Hillary Clinton was called a nasty woman in Wednesday's evening debate, since that time on social media, nasty woman has come to be celebrated as a way to describe women who are successful, driven, and have a huge impact on the world. And so today I am also awarding Dr. Ali the Nasty Woman Award as well. So thank you so much, Dr. Ali, for being here today, and I'll leave it to you. Let's give her a warm welcome.
Thank you, Madam Chair, for that introduction and the award of Nasty Woman. And I wish to thank the Henry Ford initiative and the organizers of this conference for inviting me to participate in this meeting. Where is my? Oh. For the purpose of this session, the term of reference for partnerships and clinical capacity buildings are shown on this slide. The partnership definition was taken from the UN General Assembly Resolution 62/211 in 2007. Clinical capacity building involved working with individual workforce at the individual or workforce level to improve knowledge and performance, skills, and competencies. And as you all are aware, developing countries with limited human and financial resources often seek to build clinical capacity through partnerships to improve delivery of service. A little bit about Trinidad and Tobago. We are about 7 miles off the coast of Venezuela, and it's the most southern twin island in the Caribbean chain. Our capital is Port of Spain, and we have a population of 1.3 million with an area of 1864 square miles. We have a rich culture, and some of you may recognize some carnival pictures. There are many festivals that we celebrate, for example, Hussein, Diwali. We are also known for sand and sun. Our main economic driver is petrochemical, and there's a picture of an offshore well. And we're the land of steel band and calypso. I'm now going to address you on 2 special projects that I've been the initiator of. And the first is looking at the development of competency in managing the HIV epidemic. So in the late 2007, 2008, the Trinidad and Tobago government agreed to access funds from PEPFAR to assist in the mitigation of the effects of HIV through training. A training needs assessment was undertaken, and as a result of the results of the training needs assessment, I recommended that we develop Trinidad a health training center to deliver the program. The reason being that the university where I work engaged in degree granting training, and the healthcare workers were interested in coming because they had the added perk of getting a certificate with the University of the West Indies stamped on it, which is a great incentive for them. The training center was funded by the government of Trinidad and Tobago and external donor PEPFAR through University of Washington, Seattle, ITech, and the University of the West Indies gave staff time. Following the training needs assessment, a strategic plan was developed for training over 5 years, and these are the 4 strategic framework which were identified: curriculum development, needs-based training, monitoring and evaluation, and research, and resource mobilization, together with strategic partnership. So the accomplishments of that partnership are as follows. Curriculum development: we developed 21 training workshop curricula for workshop duration of 1 to 3 days. We also developed a postgraduate part-time diploma program in the management of HIV infection, which is 1 year long, and it is being delivered in the blended format. So we have online content area together with a practicum and research. Monitoring and evaluation: we we wrote 21 reports, we engaged and completed 7 research projects, and presented over 30 papers at regional, local, and international HIV conferences. Research mobilization and strategic partnership is very important, especially from the point of view of funding. During this project, there were difficulty in recruiting healthcare workers to train because we have a very small healthcare workforce. And if you move workers from their workstation, then there is a shortage and they're unable to deliver the care to the patient. This shortage, the difficulty was particularly at times when there were public holidays, when at school holidays, and also when staff members took their personal holiday time. So in order to get around that, we trained for about 10 months of the year, and we used the other 2 months for writing reports, etc. At one point when we started, there was a lack of trainers to deliver some topics, particularly in the area of stigma and discrimination and psychosocial support. So we developed training of trainers, curricula, and we were able to train a cadre of trainers to continue with that work. Because of attrition and mobility of healthcare providers within the service, sometimes it was difficult to locate members of staff whom we had trained, because the service is such that anywhere there was a shortage, staff would be moved to cover that service. Anyway, we were able to track the members of staff whom we trained to allow us to evaluate the training. And there was difficulty in maintaining financial resources to continue the program. So I will now tell you about the UE telehealth program, which is different from the HIV program, which is mainly upskilling healthcare providers. This program was one of developing a service to care for or to treat patients, pediatric patients mainly, whose parents could not access health care abroad because the country did not have the expertise to either diagnose or treat the child's condition. The program was also aimed to strengthen the education program, so there was a teaching element to it, and also a research element to the program. I developed this program in 2004. I wrote a proposal, and the proposal was accepted by the Herbie Fund, which is administered by the Hospital for Sick Kids in Toronto. And the government of Trinidad and Tobago gave a small subvention, but the main subvention to run the program came from corporate sponsorship in the oil industry. So the benefit of this program was that there was a short waiting time for consultation for these children. There was increased local access to one-on-one specialist consultant, and during this one-on-one access, the patient was able to speak to the overseas consultant, and there was transfer of medical information and teaching that normally would occur during a patient consultation between the foreign specialist and the local doctor who was treating the patient. This program was cost-effective as far as we're concerned. Over the period, we assisted 283 families. We had 276 consultations. We also had consultations for patients from Guyana, from Grenada, and other Caribbean islands. And we were able to have a cost saving of approximately $2.4 million US on surgeries, because all the children who required surgeries, they were hosted by the Herbie Fund. So what was needed for this program was to identify the children, to maintain the program, mainly funding, because the doctors who were involved in it locally did it free of cost. The funds that we access through our partner went to paying sick kids specialists for their consultation, so it was a fee for service. And we'd say, was it worth the investment? And I think that
I've been involved with the Telehealth Initiative for the last 10 years since its inception here at Eric Williams. It is a very useful resource for physicians and surgeons at Eric Williams because it allows us to get consultations, second opinions, and possibly referrals to tertiary institutions away who have resources that we don't have here, so that we're better able to manage our patients.
Brittany was born with congenital heart disease, clubbed fingernails, bloodshot red eyes, unable to stand, run, or walk for any long periods of time. I was browsing through the UE Stand magazine, and I came across UE Telehealth. We didn't have to go through the online conference and whatnot. She was immediately granted, because of her situation, the funding and whatnot, and we are grateful for that. I am ecstatic, I'm happy, I'm grateful. Brittany can now ride a bicycle, she can walk with the dogs. We play cricket, we play football. She does a little bit of swimming. Telehealth, thank you so much. Without this life-saving surgery, Brittany could have not done anything at all. She's more of a young lady now.
I am very grateful to the Telehealth Initiative because we have quite a small population, 1.3 million. So some of the cases that we get referred here are very uncommon, and we often don't have either the resources or sometimes the expertise to manage them as best they should be managed. It allows the patients to get that second opinion that they often want without having to travel abroad for it. It saves the families hundreds of thousands of dollars by being able to get that appointment or that consultation here locally with a hospital abroad.
Tyrese is the side of a twin. Tyrese was diagnosed with bladder extrophy. That is the bladder protruding out of the body. From there, it was like we were in panic mode. Because of the rarity of Tyrese's condition, her first statements were that, yes, he can be helped. That is when she introduced us to telehealth. When you look at the financial aspect of conducting an operation of this nature, is a God-given gift then to us, because I don't think we would have been able to afford it financially to do anything like this.
There are also other telehealth initiatives where we have grand rounds, teaching rounds, so that doctors here can sit in on teaching rounds in another institution and we can learn from their experience. we can also present our cases, difficult or complex cases here, and they can learn from our experience here. So again, it's an exchange of knowledge and experience.
Knowing that he is so close, and it would have been yet so far if we had was to source the finances. The moment that, you know, that, hey, we've been accepted and we're going to sponsor the operation, I mean, you couldn't want more than that.
Thanks to you, Telehealth, putting us on the right track, giving us the guidance. I wish that all parents who have children that needs life-saving surgery like this would come to you, Telehealth.
So that program was started in 2004, and in 2011, because of difficulty in treating children with cancer and blood disorders, an offshoot of that program was developed, and that program called Caribbean Sick Kid Initiative for Cancer and Blood Disorder has 6 islands within the Caribbean involved: Trinidad, Jamaica, Bahamas, Barbados, St. Lucia, and St. Vincent, with UE Telehealth being the hub. So this slide really speaks to the lessons learned from developing those 2 programs in Trinidad. And although it's not there, what we were told this morning by our featured speaker is very relevant to the development of these 2 programs. So you need to ensure there is alignment of interests, need to communicate and collaborate, you need to have robust governance and support structure. One must remember at all times that the partners may withdraw, which happened to the original UE Telehealth program, where the oil companies have terminated their support because of the price of oil on the international market. And it is very important that when developing partnership, you must always take into consideration the local context and ensure that you have local ownership. It's good to get foreign help, but if you make the mistake of giving up your local ownership, then it's lost forever. You must also incorporate monitoring and evaluation into your program to see whether or not you're wasting your time and effort. And it's important to think and plan long-term and to always be flexible. So I thank you. I have a small YouTube. Do I have time? Do I have any more time? Oh. Okay. So this is a nice video, I think, showing the effect of partnership in clinical medicine. Oh, okay.
Families.
We are children.
We are supporters.
So
And
this
we
program
are
has
investors.
different
We're influencers.
We are movers.
We are teachers.
And we are learners.
We are building relationships and partnerships so that we can exchange ideas
And build sustainable capacity.
Collaborate on new initiatives.
so that we will advance the diagnosis and management of pediatric cancers
and blood disorders
to better the lives of
all of our children.
Together we will.
Together we will.
Together we will train and study.
Share our experiences through
telemedicine,
track our children's progress and outcomes,
participate in patient review rounds,
improve laboratories,
change how care is delivered,
and reduce
childhood mortality.
We are changing our world together
in ways that will make us all prosper.
Together, we
are Jamaica.
We are St. Lucia.
We are Trinidad and Tobago.
We are the Bahamas.
We are St. Vincent and the Grenadines.
We are Barbados.
We are countries all over the Caribbean.
We are Sick Kids Hospital.
We are the University of the West Indies.
We are the future.
And we are one. We are one.
We are one.
We are one.
And we are changing the world together.
Because we are all of us together as one.
Thank you.
Thank you so much, Dr. Ali. Our next panelist is Dr. Joseph Kolars from the University of Michigan. He is Professor of Health Professions Education and Senior Associate Dean for Education and Global Initiatives at the University of Michigan Medical School. You can refer to the program for a more extensive bio of his impressive accomplishments, but I must say that as a student at University of Michigan Medical School, I was able to participate in his Global Reach program, and it was a formative experience for me. So I'm very grateful for the work that he's done. And without further ado, please welcome Dr. Kolars.
Thank you, Dr. Connolly, and the Planning Committee for honoring me with this opportunity to be with you here today. It's great to see so many University of Michigan people, but I'm so impressed with the hospitality that Henry Ford and the global program here is really showing all of us. So I'm very grateful for us to be a part of this important event. I wanted to offer you some of my own perspectives on building clinical capacity through partnerships. As you probably heard, I'm an education dean, so I'm in the business of developing people, the human resources for health. And I run a unit with some of our folks that are here today called Global Reach. Reach is actually an acronym for Research, Education, and Collaboration for Health. If I had to pick one letter that I think is the most important, it's the C, the collaboration. And the talk I'm going to provide is really going to emphasize this collaboration around capacity building. And what I'd like to do is offer really two aspects. These are case studies from academia. One is, what are some of the examples of this? How are we navigating this opportunity at University of Michigan? But also I'd like to speak more towards a macro movement that's called the Medical Education Partnership Initiative. So those are the two different perspectives I'm going to offer today. So lots of times when people think of universities, they think of the academic medical center, and we're really focused on these three missions: research, education, clinical care. And that's usually what academic institutions are focused on, those three missions. And when people think about global health, a lot of times they'll think about an academic medical center in terms of, are there students going into global environments? What are the opportunities for medical students? So if I was to show you an example of that from the University of Michigan Medical School, over the last 5 years, we've had about 324 students that go off into these places. So often I find academic institutions talking about global health in terms of activity, and unfortunately it's often about activities that benefit them. I mean, that's how they express what's going on. But I think there's some real risks from the way academic medical centers navigate this space. You know, the power of the ivory tower. You've heard about this a little bit from Dr. Gloyd earlier today, that academic institutions are often in the business of doing what we call ivory tower polishing. You know, they're writing papers for themselves, they're doing things that kind of build their own infrastructure. But how does that tie in to the global health mission? How does that tie into collaboration and capacity building? Again, yeah, sure, we send our students out, other places do, but what's the value proposition to areas around the world, particularly the low resource areas? As you heard from Dr. Gloyd earlier, one of the things that's part of the agenda for academic medical centers, especially places like University of Michigan, big research center, is to get research dollars. So funding for global health has really altered the playing field. If you look at what's happened over time, and look on the left there in terms of what the US dollars are, there's lots of funding. There's lots of things that draw people into the global health space. Now again, academic medical centers sometimes are doing this collaboratively, but too often they're doing it to suit their own needs and to really advantage their own agenda. So I think that is really problematic. What I see when I travel the world is often there's a kind of a new colonization that's going on, and that's academic medical centers going off to different places and say, we're going to put our flag here, this is our place. Oh yeah, you know, Hopkins is in Uganda. You know, in different places we'll try and claim regions. And I think there's a bit of an arms race going on out there right now in terms of academic institutions and what they're doing in terms of global health. Meanwhile, I think many have come under criticism, the academy, but also all of this global health funding. Is it really all going to good? I wonder how many of you have read one of these books, White Man's Burden, The Great Escape, or Dead Aid? Anyone read? So one of the common messages here is that how we can inadvertently do harm while we think we're doing good, all right? That often when we go in with money, good intentions, a bunch of do-gooders running around, we can often have very inadvertent consequences. I think there's a real call for communities in advantage areas such as ours to be a really respectable and valued partner to those who are really on the ground trying to work on things. I think this comes up a lot for those of us like I do who deal with students and more junior learners. And you know, the things we're always trying to be mindful of are kind of the pluses and the minuses of education tourism. You know, when I was a medical student, I got started by going to India, and I was working in Nepal, and I got to work with Mother Teresa, but I was an education tourist. And sometimes I had a hard time understanding what are some of the downsides to that. I'm going to help. What's wrong with that? Well, for those of us who spend a lot of time in other parts of the world, sometimes this flood of learners that are coming in, especially when they're positioned to say, I'm here to help you, isn't always true to purpose. Often there's mismanaged expectations. There's the lack of staying power. These people are kind of going in and out. Voyeurism, I'm here to look, kind of prowl around your home, see what's going on here, take some pictures, do some blogs, then the message back. This false premise of importation of Western solutions, we tend to be culturally insensitive. Often our learners, or when there are people like me in this space, we can be very distracting. There are people who have to take care of us and make things happen for us. We tend to dangle things that are out of reach. Don't you wish you had that? This is what we have back at our place. Motivating people to move away and creating inadequacy and dependency. So these are some of the ways that academia sometimes can go into these arenas like a bull in the china shop. And I think we're really called upon to be better than that. And that's something that we've tried to do at the University of Michigan, and to really prioritize the meaning of the word collaborate. If there's anything that we want to be known for in terms of our global initiatives, is how we out-collaborate other people. How can we be the best partner by the way we enable and hopefully make ourselves obsolete. One of the things we've done institutionally is we've tried to organize ourselves into platforms. So what's a platform? A platform is multidimensional. It crosses departments and schools. It attracts others who are interested in synergistic partnerships. So where do you find our platforms right now? We have got one in Ghana, one in Beijing, one in Sao Paulo, Brazil, one in Delhi, India, Ethiopia, and Israel. And I want to just give you a few samples of some of these platforms to show you what I mean when I'm talking about collaboration, but more importantly, for purposes of this conference, how does that relate to capacity building? Are you just, writing papers back home, or are you doing something that really enhances capacity? So let's just take a couple of these platforms for a few examples. One is our Ghana platform, focuses on human resources for health. That's a 20-year history with our Department of OBGYN. The problem statement is that there weren't many obstetricians, gynecologists in Ghana. The number of women who could have a skilled healthcare worker when they were delivering were few and far between. And people would leave Ghana to get OBGYN training, and wherever they would go, they would get trained not to fit in back home. You've learned what you need to do to function in this environment where we've trained you, but that's not going to work back home. So what seems like a pretty obvious solution right now was new at the time, and that is, let's go and move training programs in country and actually start to train obstetricians, gynecologists, midwives, the team. And so far the department has trained about 100. Only one has left. All right, so there's a little bit of a false notion that people just want to be trained to get out. People, like all of us, want to be in our homes, in our home countries. And they would like to have the training and the enabled there. So we have a long list of partners that has been critical for our co-development. Not only has this happened in OBGYN, but now we've gotten this as a trusted model to be able to say, how can we extend this for capacity building in other topic areas? So we achieved some funding from NIH to start emergency medicine. There was no such thing as an emergency medicine program in Western Africa. There's not one now in most of Africa, except ours at Kumasi, where again the goal is to train people who can actually do emergency medicine, can teach emergency medicine, and for us to make ourselves obsolete. Does this help us? It does. It's a training venue for our folks. Of course, we write papers and we get grants. But the most lasting impact, we would like to think, is on capacity building in terms of really building the field and developing the discipline of emergency medicine. So meanwhile, as we're doing this capacity building, where can you find other evidence of our work? It's in a number of our departmental collaborations. We do cross-school collaborations with public health, nursing, dentistry, engineering. We develop mutual educational resources. And we're also very proud of the fact that we bring Ghanaians here to study with us. One of the things that really troubles the low resource areas of the world is that we charge our students tuition and then we send them to other places to be trained and have a great experience. Usually those tuition dollars don't follow. And it's very hard to reciprocate. So one of the things that we've really tried to advocate the meaning of being a good partner in capacity building is to offer that back here. So while we've had about over 37 students now by this time, we've actually brought 87 Ghanaian students back here. So we think that's the meaning of collaboration, partnership, in structuring these in a collaborative way. Ghana platform. What's another example of a platform? One is in Beijing, where we have a joint institute for clinical and translational research. This is focused on capacity building around clinical research so that people can work on clinically relevant problems. So we look at topics where we could advantage each other by looking at them through two different lenses. One of the things that's really common in our setting here is people with lung disease, COPD, things that lead to lung cancer. Well, that's also a problem in China. China also has most of its people still smoking. Most of the doctors still smoke, and the pollution is awful. So if you're trying to study diseases, it can be useful to compare and contrast and to try and find mechanisms and how are they exploring themselves. You know, most people who smoke don't get cancer. Well, why can we try and pinpoint those who do? So it's a real platform for capacity building around clinical research. So we have a number of programs and we have cores. For me, when we're thinking about our platforms for global initiatives, probably the most important core for me is always the science of collaboration core. Again, people use that term quite loosely, but most of us don't get it right in terms of really trying to listen and have the humility to understand how does this look to somebody else. Whenever there's people like me who show up with money, people will do whatever they can to get that money from me if I've got a grant or something else. That's the way all of us would be, human nature. But how can you truly collaborate? We try and really focus heavily on that. Last platform I'll mention is that one that's in Ethiopia. Most of these get ignited by the passion of an individual. We're not sitting with a map at the University of Michigan trying to figure out where's the target. It's somebody who's got a passion and an idea. And for Ethiopia, it was Sinai Fisea. Tried to take that model that you heard about in Ghana and to say, can we do what's called a south-to-south collaboration, capacity building? Take some of the lessons we learned from Ghana and bring those to Ethiopia. So we have a number of now training and development programs. It's a very popular place for our students, for our faculty, for our residents. I know you've probably seen some posters here and some of our faculty and team that work on things with Ethiopia. Again, it's a very dynamic platform for us where we think about capacity building for clinical and research for Ethiopia, but also for us. It really advantages our learners and our faculty to have the ability to work with really strong partners. So I think it all depends on how people go into these situations. One of my favorite quotes that I'm always reminded of when I think about collaborating and capacity building in this space is it's an Aboriginal quote. I wonder if many of you have seen it. If you have come to help me, you are wasting your time. But if you have come because your liberation is bound up with mine, then let us work together. And I think so often many of us in academia don't go in with that kind of attitude, but that's something that we're really trying to emphasize. This is a balancing act for us, and for our partners, many of them want to strengthen their schools, their training programs. They also want to have fulfill their civic responsibilities, create a workforce for their ministries, develop the capacity around human resources. Sure, if we don't have an agenda, these things don't end up being sustainable. You usually have somebody passionate with a good heart, and then they wear out, they burn out, they peter out. So you've got to try and figure out what that win-win is that can be mutually synergistic. And for us, these are the aspects. We also try and pay attention to what we think of as the science of collaboration. How can we learn to be a good partner and to be a respectful partner? And again, these terms end up being thrown around a lot, but I don't see them in practice as much as I would like. So that is my case studies, and give you a little taste or flavor of what we're doing around capacity building at University of Michigan. I want to now jump up to a macro level. What are some of the big movements that I see going on that are examples of capacity building? A lot of times it's easy for people to see research going into a new vaccine, getting on top of the epidemic of Zika. But what's going on in terms of actual capacity building? I'm going to show you a few maps, but I'm going to start off with kind of a concept. You know, a lot of times when people think about global, there's different regions of the world that come to mind. Africa seems to get a lot of attention. Do you have a vision in your mind of how big Africa is? What does it look like on a map? This picture just struck me. If you look at Africa, you could fit all of the United States, all of China, all of India, all of Eastern Europe, Great Britain, Japan. It's a big place, all right? Unfortunately, it's one of those countries that has really been beaten up by the products of colonization. It's a huge place. And it's a place where I spend a lot of time. I'm there probably 5 times a year. And I want to show you a couple of other maps to introduce to you what my passion is. What is my interest in capacity building? I don't know if you've seen these mapmaker maps. This is actually out of a paper, the Lancet Global Health Commission on developing a workforce. But if you look over there on the left and say, well, what does the world map look like if you've just looked at it on population? All right, what happens if you just on the lower left on medical schools? And then burden of disease and workforce. So I want you just to look at these 2 maps on the right, because this is the essence of my passion and what I've been trying to work on for the last 15 years. And that's this reality. If you look at the burden of the disease, if you look at all the diseases of the world, all the afflictions, 25% of them are in Africa. But if you look at the workforce, the healthcare workforce, it's actually less than 3%. So we learned this when all of a sudden we thought if we could take the HIV drugs off patent and send them in a low-cost way to Africa, we'd be on top of the epidemic. Well, we got all the drugs there. There's nobody to push the plunger. You know, there's no healthcare workforce there. So that's the space that I work in. And when I talk about healthcare workforce, I want to be very mindful of it's a very complicated team that comes together to enhance health. I work, you know, as the dean of a medical school, I'm you know, a little bit more focused on physicians. When I'm out on the global field, it's the team. Physicians are actually a fairly small part of this. So I was very pleased to see that the NIH was going to move out of just discovery, breakthrough science, just out of vaccines, but try and say, gosh, how do we get more healthcare workers? How do we get more doctors? How do we get more nurses? So this happened about 6 years ago. I was actually working with the Gates Foundation at the time on some projects that were taken up by NIH. And this is called MEPI. It's a Medical Education Partnership Award. This was actually $130 million from the U.S. government that provided twinning grants between schools in the U.S. and schools that were in Africa for purposes of strengthening. And schools competed for these. And this was actually a game-changing initiative from NIH. As you probably heard from Dr. Gloyd, a lot of the money that flows out of our research endeavors first comes to a U.S. school, then we take a bunch of it off, and then it trickles out to Africa. For this initiative, all of this money first went to Africa, and then Africa would purchase what they wanted back from the U.S. schools. So that's partnership. Suddenly they're in control of the money and of the agenda. So there were a number of schools that applied for this, and these schools each got to pick their northern partner in terms of picking their partner on the basis of who can help develop us, who can help develop our clinical and research capacity. So the Medical Education Partnership initiative has been going on for about 5 years. There's also been one for nursing. But let me show you one of the things that came from this. So this dot these dots just represent the 13 different schools that actually got these grants that went and purchased input from the northern schools. So they're in a variety of countries, and most of these countries aren't used to connecting with each other or working together. But over a period of 5 years, I was able to really work with this community in terms of how the schools started to partner and collaborate with each other. So if all of a sudden you started to connect these, you got connections like this, where all of a sudden you had schools that were connecting with each other, trying to share best practices. You had schools that were connecting back with their institutions in the north, schools that were connecting with their own schools in the country. This is science of collaboration. How do you all of a sudden get people coming together to work on common issues around capacity building? So is this just activity? No, this is scholarship. This is trying to figure out how can we figure out how to do this in a way that's generalizable, and other people can do that. And you can read about this. One of the big journals is the Academic Medicine. 33 articles from 226 authors. I was so proud of the fact that 66% of these authors are authored by our colleagues in Africa. All right, and 40% of them are coming from more than one institution. So it's a real coming together and trying to develop the capacity for those schools to be producing and doing what they need, not to be dependent on people like me coming in and out and doing things for them. So we did a little bit of a summary on this, trying to say, well, what are the benefits of growing partnerships and the power of collaboration in capacity building? One is learning to partner with diverse stakeholders. Most collaborations are individual to individual, so we were trying to figure out how do you partner diverse stakeholders together. Creating a community of practice to strengthen medical education. A lot of people don't come together around medical education. They're coming together around a disease, an epidemic, a scientific opportunity, but education. An improved culture of collaboration among universities, communities, and ministries. If our U.S. healthcare system were to design an education system to fix our healthcare problems, it probably wouldn't look like it does now. All right, we often are not in alignment between how we educate and train and what the country needs. And that's very true in Africa too. So this initiative was really galvanized that coming together. More profound respect among northern partners for self-determinism among their African counterparts. Finally, they get the money, they get the agenda, they get control over what's going on. Sure, it comes from NIH, you have to follow NIH rules, but they're not following my rules, University of Michigan rules. And then advancement of performance metrics to strengthen health science schools. So, all right, if the goal here was to enhance capacity, how many more schools are coming up? How many more graduates are coming out? How better prepared and trained are they? So that was my second kind of case example on more of a macro level of, for me, what does it mean to try and really focus on collaborative partnerships for purposes of capacity building. This latter one was a little bit more in medical education. But now this is a movement that's underway that I hope is going to be transformative in Africa. It's certainly been transformative for me and many of my colleagues. I'd like to end with an African proverb. If you want to go fast, go alone. If you want to go far, go together. Thank you, and I appreciate the chance to be with you here today.
Okay, now we have some time for questions. I will start with one as people make their way to the microphone. And I think we had a very thought-provoking day, and our keynote speaker this morning, I think, brought up some really important questions about the utility of these types of collaborations. And so I'm going to get into, I think, a couple of tough questions here, because we have two really insightful speakers up here. So the first question I have is for Dr. Kolars, and then Dr. Ali, I'll have a second piece for you as well. Dr. Kolars, the second part of your presentation focused on the continent of Africa, which is comprised of 54 countries, many of whom have multiple cultural contexts within them. Those borders are arbitrarily drawn and don't necessarily even reflect the reality on the ground. So there is an immense amount to learn about each of the many countries that these partnerships have formed in. So with that in mind, does that amount of cultural learning on the part of, for example, American partners, that takes a lot of effort to really come to understand the cultural context of, again, the many different locations that UM is collaborating with. Does that effort and time, how does that compare with what you're bringing to the table in terms of expertise in education and that type of thing? I think the amount of time and effort that it would take to really become comfortable in each of those contexts that you're describing is immense. And so what in your mind is the reason why those funds and those grants should go through a higher education institution in the U.S. versus going straight to like ministries of health and medical schools abroad?
Sure. First of all, you're absolutely right. When you look at that map of Africa, there's a tremendous amount of diversity, and it's a product of colonization largely. There's only one country that was not colonized. Ethiopia, okay. My MR tie in its honor right now. So most of these have been left with a legacy of an education system from their colonizers, which is in various shape. One part of your question is how can you kind of manage all those different things? I'm one of the few people that, because I'm part of the collaboration, that I go to the different places, but for most part it's one school in the U.S. partnering with one school in Africa, so so that they can actually get to know them, not be hopping all around and having these little brief intimacies, but really get to know them and be working with them over time. This was a big change because NIH, as you probably know, is a government institution, and so all of us, and they're responsible to Congress. So all of a sudden, to change their mandate and just say, we're going to send these research dollars out of the U.S. for somebody else to manage and to handle, and we'll turn them over to the ministries of finance or education in these countries, which have varying degrees of accountability, much like our systems. That's why I think the design was to be able to say, no, we need to still have the U.S. partner there. It's U.S. dollars, but we want to have the partner that's in the South in the driver's seat.
Okay, great. And then Dr. Ali, in your context, getting to know, for example, your clinical colleagues in Toronto, right? So from your perspective, how has that kind of cultural exchange and conversation taken part? And, what have you learned about Canadians that perhaps you didn't know before?
We have a very long relationship with Canada, and in particular, hospital for sick kids. I have done research with their staff eradication of premature babies, and that went on from 1979, long time ago. And I maintain my links with the Hospital for Sick Kids. So it went from research, invitation to colleagues at Sick Kids to come to Trinidad to deliver lectures at the university. And also, when I had a newborn with a problem, it was easy to take up the phone, call, and ask for help. And then, so I will get the medical help in Canada, and then connect my local connection to get free airfare, etc. The other things that go with the management. So it's really personal touch.
Got it. And it sounds like a very long-standing relationship as well. Okay, any questions? Nobody else? Okay. You know, just because again, this is something that I think is, you know, I think is really important to thinking about international relationships. I'm interested if both of you could each point out something that in terms of when you're starting a relationship, what are some indicators in your mind that this is going to be one of mutual respect and kind of as things are starting to materialize between partners? I'm interested in how we can determine if whether or not this is a true, genuine partnership and kind of what you've both learned in your many years of partnership development.
Well, I think the first thing is to identify a partner with with common interest and someone who is really passionate with that. Someone whom you feel that there is trust and there is openness and understanding. And when I say openness, I mean not only with regards to the area that you're going to work together in, but also look at the funding, the budgetary allocations, etc. So those are very important points.
Which I think are things we've been hearing all day as very,
Yes.
very important things. Dr. Kolars?
I think there are two attributes that I would look for early on. First of all, is somebody going in with questions and really trying to understand what the local situation is and to listen carefully to what the needs might be or where things may have a chance to be helpful. So, so often those of us who have been tremendously advantaged will go in with, you know, kind of our wares and a menu, but we also have this hidden agenda. Boy, you know, I could use another 200 people with lung cancer for my study. And then so often people are going in to really pitch to say, you know, I need something, but let me try and convince you why this is going to be really good for you. All right, so that's often the dynamic that's going on. So I think that the starting off positions is if somebody is really going in with the trying to ask questions and to deeply understand what is the needs, what are the wants, the wishes, and what's the local context. And you can never spend too much time trying to understand that. So, so if that's one of the first moves on the dance floor, I think that's great. Another equally important move is for people to be able to express clearly and manage expectations in terms of what we have in more advantaged positions to be able to offer. Because there are so many people in situations I find in the global south or in low resource areas that they see a parade of people like me trying to come in and assess their needs and their wants and their wishes. in hopes that maybe I can go back and write a grant or find money from somewhere. And they're all looking to say, gosh, does this guy have money, or does he need something for us to get money, and how do we answer the questions so we are his partner, that we get some of the money? And I find that to be a little just disingenuous, and I think a lot of the people have gotten a bit weary out there for seeing, people like me again and again and again, when in reality they actually need resources and they need help that they are defining. And I think it's really important to define that expectation and do expectation management up front. Because it's like any relationship where there's a power dynamic. And that's probably the last thing I would say too. I think for those of us who have been so advantaged, we have to, no matter how hard we try, we have to be really mindful of the optics of having power in the resources and things like that. Because when you go into these situations, you can really tip the balance. So I think it's a very careful, cautious, driven by deep listening. Where could we be helpful? What are you looking for?
Okay.
We can take one more.
Yeah.
It's a short one should do.
Yep, we have a question
Okay.
over here. I'm sorry, we only have time for one more. Go ahead.
This is probably better than mine, but anyway. So, Dr. Kolars, as you said, collaboration is a term that gets thrown around a lot, and you referred several times to collaboration science, and it appears to be a part of the core of the Joint Institute. Could you talk to us a little bit about what collaboration science is, and also, isn't it also as much an art as a science?
Yeah, thank you, Chineri. I think you're absolutely right. I think collaboration is as much an art as a science. I think that's an excellent point. To me, it's trying to understand how can you get people connected for a mutual purpose, but also how can you help, how can you kind of help and anticipate the types of bumps that can come up in any relationship, and that you need to smooth that out. And I think some of these are generalizable. Maybe if I can introduce just briefly our Science of Collaboration core for our Joint Institute in China. China, I lived there for 3 years. China is, it's been a booming economy, and everyone rushes into China saying, if I could just get 10% of the people to buy my bar of soap or my car. So there's tons of, probably 10%, 90% of the joint ventures in China right now fail. It's not because of hard work. It's not because there isn't a good idea. They haven't been able to connect culturally. There's a language, there's a time, there's a dance, a way of doing things that people aren't mindful of and respectful of. So what we decided to do with this joint initiative is to say, listen, and then, what typically goes on with research initiatives there is everyone starts off and it's great, it's wonderful, and then the first problem happens and the wheels come off. So what we said, you know what, this is too good. We're going to have problems, right? We're getting married, we're going to fight, we're going to do this. We're not going to let a fight or a spat just end the marriage, right? Can we figure out a way that we can work through these and at least in that setting, there's a number of behaviors and dynamics that we've learned about how to collaborate. And I'm mindful of the time. I'd be happy to speak offline with people, but there's a number of things that we know that we didn't know before how we were going to make things happen in China. So we've got kind of our field manual, our book, our paper on how to make those things happen. Some of those would be generalizable to other cultures, but a lot of them is trying to say, no, let's save some time that we're going to talk about how are we working together. Forget the science, forget the capacity, but how are we working together? And to try and create room and space for that, I think, is important.
Okay, thank you. Let's give our panelists a big round of applause.